Good morning, everyone. I'd like to call to order our meeting of our Behavioral Health Committee. Thanks, everyone, for being here this morning. Madam Clerk, would you mind calling the roll for us?
Chair Brayback.
Here.
Representatives Arbit.
Here.
Pahutsky. Here. Glanville.
Here.
Edwards. McDonald. Reingens.
Here.
Schmaltz.
Here.
Hoadley.
Here.
St. Germain.
Here.
Thompson.
Here.
Madam Chair, you have 9 members present. You do have a quorum.
Thanks so much. I appreciate it, Madam Clerk. Rep. Glanville approves and adopts the minutes.
Yes, I do.
Thank you so much. We appreciate that. And welcome back, everybody. As you'll remember, the last time that we got to meet, we got to hear testimony from parents with kids and young adults who have really complex mental health care needs. And they shared with us of their experience, both themselves and with the system. And today, we have in front of us several members from the Michigan Federation for Children and Family, so our provider side, who are going to be talking with us again about the complexity when we have children and young adults with very complex issues, so that way we have a much more comprehensive view of this issue. So I want to take a minute and thank Janet Reynolds Snyder, who is here. She's the executive director of the Federation, and I'm grateful to her for all of her work and leadership and partnership and the work that she does and leads throughout the state. So thank you so much, Executive Director. And with us, we have 4 experts who can help us understand these issues even more. We have Deborah Matthews from the Children's Center. We have Sean DeFour, from Southwest Solutions. We have Carrie Walker, who you all have seen before. Carrie is from the Guidance Center. And we have Dr. Bob Powell from Family Services and Children's Aid. And so with that, I'm going to turn it over to them. I've asked that each one of them talk for about 10 minutes and share their thoughts for that long, and then we will have an opportunity to be able to ask questions after that. Any questions, team, before we start here? Okay. All right. Ms.
We're
Matthews, would you
on.
mind starting for us?
Absolutely.
Thank you.
Greetings to
Good
each
morning.
of you, and much thanks for the committee allowing us to come forth, Representative Brayback and others who many of us have spoken with over the last several weeks, months. We really appreciate this opportunity. I'm so glad you had parents come in first, because I think that's a key part of what we do. Most of us serve children from, in our case, pre-birth, working with parents and moms, and all the way through 21, some through 25. So having some of that perspective ahead of what we're talking about, I think is critically important. As the chair indicated, we are members of the Federation. Many of us have been a part of the Federation under Janet Schneider for, I know for us, probably 20 years, and maybe longer for others. A valuable resource. So we're glad you reached out to Janet. They're always here to support the subcommittees and anyone in the legislature that needs information. So the Children's Center of Wayne County primarily provides behavioral health services. About 70% of our $21 million budget is in the behavioral health area. We are 94 years old, so we've been around a very long time in the Midtown Medical Center, Wayne State University area, which at this point does not contain tons of families in the neighborhood, although Midtown is definitely growing and coming back. So primarily our clientele would be in the inner city Detroit, but all of Wayne County is what we have a contract with Detroit-Wayne Integrated Health Network to provide care. We also provide child welfare services, so the foster care and adoption side of things is also a great part of what we do at the Children's Center. And of course, with foster kids, there are challenges with respect to dealing with both the birth family and the foster families. And so having that behavioral health arm also at the Children's Center helps with those challenges there. So what I'd like to share today with the group are a couple of areas that I think are critically important to what's going on in behavioral health throughout our state, and in particular Wayne County. So all of us would love to are glad that we are, for the most part, I believe, beyond the pandemic. 3+ years of severe challenges globally. And in this area, Wayne County and this entire state, children were really, really impacted during that time with the shutdowns and the isolation. Often children feeling suicidal is what we see a lot of now, and just the depression and anxiety that goes with not only being a child, especially in adolescence and the teen years, but that level of isolation and not being able to be with your friends created additional issues for many of our youth in particular, and setbacks in education. So there were many months, as we know, where there was a total shutdown, or kids were having to go to school virtually, which was a challenge. And at the Children's Center, we had to jump in right away and, of course, help families get up to speed with technology and ability to work with through telehealth, which was a great opportunity for them to keep on with the care that their child needs. Most of the time that worked out extremely well, but with the stress, the physical illnesses that were out there, and losing family members, and the grief that children went through and families experienced, even having telehealth was not always a way that they could engage with us. So we have been, over this last year and a half in particular, trying to re-engage families into the care that their children need. So we really understand that access continues to be a challenge in our community. For the Children's Center, and most of us, I believe, the access is hampered by the fact that we have a severe workforce challenge. We lost many, many clinicians during this time frame in COVID. And the thing that challenges me and really hurts my heart about that is it's really created and exacerbated an equity issue, because many of those that we've lost in terms of the workforce, the professionals that work for us, are no longer attracted to doing work for folks that come to the door with Medicaid coverage because of the challenges administratively and otherwise that they have to deal with. It's much easier for them to start their own practice and not accept Medicaid coverage, or work for a for-profit or other type of organization that does not accept that coverage. So you've got folks in the inner city of Detroit and beyond who now don't have the level of access that they need because the clinicians aren't there, the psychiatrists aren't there, the social workers are not there. So we continually land at about a 30% deficit in that area in terms of staff, which means we have to turn families away. We have to delay them getting into care. And so we've been strategizing about how to deal with that workforce issue. We've gotten some assistance from our local PIHP, and of course the state has done some great things with loosening the licensing rules so that we have better access to the types of professionals that we can employ. All of that is wonderful, but that workforce issue is still there. You figure inflation and other things, it means that our costs have increased. We're trying to pay our staff a wage that they can accept and live and pay all their debts, which most of them come out of college with $50,000 or more in debt. So you've got issues related to how I pay back this debt. If you can only pay me $50,000, how am I going to pay my $60,000 of school debt? So some of the things I think that the state has done to help in those areas and introduce new loan forgiveness opportunities has helped us. But the access for families and children who need us will always be hampered by not having adequate workforce. So we really encourage this committee, to any degree that you can, to support initiatives that will help with that access, including telehealth continuing to be an option as part of it, and then the licensing rules that were lessened, and we got some waivers on some of the requirements for those that we hire. And then, and I'll kind of transition now to the cost of things. With inflation, as I mentioned, and other areas, that means that our costs have increased. And in order to pay a competitive wage, we need the dollars to cover those costs. And what we found is that oftentimes, through our state, of course, the PIHPs get dollars and they don't all choose to pay, particularly children providers, equitably, I believe. So we end up in deficit and not able to continue programming that we'd like to. So the point is that there should be a type of payment methodology that covers the cost of those that are providing the service. You know, we are not trying to make profit. We're all charitable organizations. We all try to do fundraising, but it's really tough when you can't cover your basic operations and administrative costs because of the fact that the burden under Medicaid funding is tremendous in terms of paperwork and documentation required. So we have to be able to cover those costs. And I know Milliman is a group that had been working with the state department and to determine those rates. And we're challenged because in our county of Wayne, the costs, the amounts that get paid to us on the fee-for-service basis does not cover it. We are short by 25 to 30% of the revenue we really need. So then we're forced to reduce programming or not pay the competitive wage. So we're really encouraging adequate costs. We've now, I think it was January or February, presented our true costs to the state. And so our hope is that now they will use Milliman and other methods to be able to set rates that we can really live off of, and thus helping the entire environment of behavioral health and the needs for our families by being able to keep a workforce in place and meet all the costs that are associated with that. So I've said a lot, and I want to definitely allow you the opportunity if you want to ask questions now, or we can go on to another colleague.
Thanks. Let's hear from everyone,
Okay.
and then we'll ask questions after.
Okay,
Thanks
thank
so
you.
much. Thank
Sure.
you, Ms. Matthews.
Great, thanks. Thanks, Deborah. Good morning, Chairwoman Brayback and members of the Health Policy Subcommittee on Behavioral Health. As was mentioned earlier, my name is Sean DeFore. I'm the President and CEO of Southwest Solutions. We're a comprehensive nonprofit behavioral health and human services provider located in Southwest Detroit, but providing services throughout the city and within Wayne County. In addition to behavioral health, we do a range of affordable housing and real estate development and economic empowerment work. And our goal is to improve the quality of life, self-sufficiency, and success for individuals and families in Detroit. So I appreciate the opportunity to share with you some of the areas that we believe are a priority for the behavioral health sector. And I'm going to add to some of what Deborah mentioned and provide some detail, but also give just a few concrete suggestions for how this body could really help improve access and quality of care for all Michiganders in the state. I'm sure you've heard from others, and I suspect that you're all well aware that we are in the midst of a pretty significant behavioral health crisis, and we've seen need continue to increase pretty significantly year over year. We happen to serve in a community in Metro Detroit that is very diverse. Southwest Detroit is about 60% Latino, about 30% African American. So very diverse even within the city of Detroit, and a population that is suffering significantly from poverty. And what we've seen is that unaddressed mental health needs in our community really help exacerbate some of the social inequities that exist, whether they're economic, or access to employment or income, overall health, not just behavioral health quality. And so we see the devastating effects of that firsthand when the folks in our community aren't able to access the behavioral health services that they need. And as Deb mentioned, we are also in the midst of a behavioral health workforce crisis. And I don't have a magic wand to make suggestions to you on how to fix that. But I do have a few concrete things that I think this committee can do and support that can help ease that workforce shortage, improve access to care, and improve quality of care for all Michiganders. And I want to highlight those three. I'll start with the first, which is the Department of Health and Human Services is working to expand a national model known as the Community Behavioral Health the Certified Community Behavioral Health Clinic Model, CCBHC. And we happen to be an organization that received some funding to equip us to serve as one of these CCBHCs. My colleague, Carrie Walker, is going to talk in a lot more detail about what these CCBHCs do. But I can tell you that as an organization that received an expansion grant from SAMHSA, the Substance Abuse and Mental Health Services Administration, to build capacity to be a CCBHC, over the past 3 years, this grant has allowed us to develop and expand our capacity and specialized services that our community needs. And as I mentioned, Carrie will give you a little bit more detail about the model and how it works, but I wanted to give 3 examples of how that CCBHC model has really transformed our community. So first, as a result of our CCBHC grant from the federal government, we were able to add nurse practitioners who work alongside our behavioral health clients to also treat their physical health needs. So we have many children that suffer from asthma and anxiety, and it's amazing how those two conditions actually interplay off of each other. And you may have seen articles recently that talked about how Detroit is a hotspot for asthma. And asthma results into higher absentee rates for youth in school and has a compounding effect over the term of their life. For the first time, we had clients who were seeing us for behavioral health who were also able to see our nurse practitioner and be treated for both conditions simultaneously. And that was because of the CCBHC funding that we received. This also applied to unhoused individuals that we saw that had severe mental illness, but also unmanaged or undiagnosed diabetes. Parents with depression and COPD, again, 2 conditions that just compound each other. And for the first time, they were able to receive care in one place for both conditions, or even have both conditions diagnosed when they hadn't before. Because of the CCBHC expansion grant, we were also able to add and expand comprehensive substance use disorder services. And for us, that included medication-assisted treatment. And because of our ability to add that service, we now treat over 80 individuals every year who suffer from severe opioid disorder. And I'm sure I don't need to tell anybody on this committee, we're also in the midst of an epidemic of opioid addiction, overdose, and overdose death. And without these funds, we would not have been able to build these services and serve those 80 people a year who I can almost guarantee their lives have been saved because of the services that we're now able to provide to them. And finally, we were able to serve 500 more children every year because of our expansion as a result of these funds. These were children who had mild to moderate behavioral health issues, anxiety, depression, substance abuse, who wouldn't have qualified for services in the publicly funded system because they weren't severe enough, and couldn't afford to get services from the private system either because there wasn't access or their parents couldn't afford it. And it was because of the CCBHC model and this funding that we were able to serve those 500 youth a year. So what does this mean? The federal government has invested for the last several years in building the capacity of organizations like ours to be certified community behavioral health clinics. We need this body to support legislation to fund the state's expansion of the number of CCBHC sites, especially in the state's most populous area, Southeast Michigan, particularly the Metro Detroit area. And most importantly, right now the criteria that the state has set out for organizations that can enter the state demonstration to be certified, nonprofit organizations like ours are not eligible. And we need this body to make sure that the state allows organizations like ours who have these expansion grants, who are able to provide the services, to be eligible to be certified this fall. We are on a grant that runs out of funding as of September, and if that doesn't happen before September, all of those services I just described to you will go away. We will not be able to afford to provide them. That's 500 kids a year. That's 80 more people a year that may die from opioid disorder, and untold numbers who may die because their chronic diseases and behavioral health issues aren't managed together. So that's the first. Second is around the telehealth and administrative burden issues that Deb Matthews spoke to a little bit ago. I want to just provide a little bit more detail on that, starting with the telehealth. I'll talk about Southwest Detroit, our area in particular. We happen to be in an area where only 42% of our families have access to reliable and consistent internet. When the public health emergency was put into place and the flexibilities that came with it for telehealth were allowed, it was a godsend for our families because they could, for the first time, access behavioral health services that they weren't able to before because they didn't have transportation needs, they had childcare issues, they couldn't afford to get where they needed to go for an in-person service, and they could access it through audio, telephone, or telehealth video if they had access to it. The problem is without that reliable internet connection and with the new policy that DHHS has put into place, many of those families will not be able to access the services they need because they don't have the devices, they don't have the internet service, or for some of our older population or more severely in poverty population, they don't have the tools to be able to access video conferencing. And so audio only was one of the best ways they were able to access care. One of the things that this body can do is ensure that the new policies set out by the Department of Health and Human Services allow audio only, and that telehealth is allowed for some of the codes that it's currently not, like case management and targeted case management. Those are common services that are provided to multi-problem families, severely, persistently mentally ill individuals. And if we can't help folks access them through telehealth or audio only, they will not get services and they will get worse, period. Second is the administrative burden for behavioral health clinicians. So our average productivity rate is probably about 55%, 60% at best, which means 40% of a licensed clinician time is spent in paperwork, in getting authorizations for care or completing various service plans. We are not going to be able to magically produce double the number of licensed clinicians to provide care, but if we could cut that paperwork burden in half, we could instantly increase our capacity by about 25 to 30% to help people access services. And so one of the things I would ask this body to do is support a statewide effort to reduce administrative burdens, make them look more similar to commercial system standards, which are significantly less, and help us stop these licensed clinicians from leaving the public mental health system and going to private practice or schools or hospital systems, because they can do what they trained to do, which is help people and not sit in front of a computer for half of their time completing paperwork. Third and final area I want to highlight is preserving and advancing efforts around integrated care. And those efforts are currently at risk because of a work group that is working within the Department of Health and Human Services, making recommendations around conflict-free access and planning. And this is going to get a little bit weedy for those of you who may not be deep in the behavioral health space, but bear with me if you would. First, let me just emphasize that the benefits of integrating coordinated care are well documented. And frankly, every form of forward-looking behavioral health model that we're investing in right now is all about integrated care, whether it's the CCBHC model I've spoken about, opioid health homes, wraparound services, patient-centered medical homes, I could go on. All of those are based on integrated and coordinated care approaches, and especially for children and adults who are complex cases, who are multi-problem families and individuals, that's the kind of approach that we know works. Part of the problem is the work group within MDHHS, the Conflict-Free Access and Planning Work Group, is seeking to separate the access to service, the eligibility for services, and the person-centered planning development from the actual service delivery. And it's being done in the name of a conflict of interest concern that has been raised that we believe is largely invalid. And if the recommendations that they're making go forward, would actually create a separate administrative entity that manages the eligibility review, the person-centered planning development, separate from the actual service delivery. We think that's going to create additional barriers for people seeking services. It's going to weaken continuity and integration of care. It's going to increase administrative costs, and it's going to make an already complex system more complex. So what I'd like to encourage the committee to do, and for those of you that really don't know what I'm talking about, it would be helpful to maybe just take this next step, which is to review the work group's recommendations, hold a hearing and ask the work group to explain to you what they're recommending and why, and also invite the Community Mental Health Association of Michigan to that hearing so they can share with you legal experts that have ruled that what the conflict-free access and planning work group is doing does not meet CMS standards, actually makes the state's compliance with those standards worse, worsens care, and isn't something that is required to do right now. So I think by advancing these three common sense recommendations, we can help ensure that Michiganders have access to high quality behavioral health care, the care that they need and the care that they deserve. So thank you, Chairwoman Brayback and the rest of the committee for hearing my recommendations. And I'll turn it over to Carrie Walker.
Okay, thanks, Sean. Good morning, everyone. And thank you, Chair Brayback and the committee for having us here today. We appreciate the opportunity to share our thoughts about challenges in the mental health system and potential solutions. I was here several weeks ago with a group of other executives who lead agencies that are part of the state demonstration of the Certified Community Behavioral Health Clinic. So I just wanted to share some additional information now about that and sort of a perspective about challenges in the current public mental health system outside of the demonstration. Michigan's public mental health system has a very robust set of services for children and families if you qualify. And that's an important distinction because a lot of studies have noted issues in Michigan, both in the private sector in terms of families who have insurance, as well as shortages that exist around the state. We have a comprehensive set of services, but they're limited to people who have Medicaid. You know, some of in the CCBHC demonstration, for example, all of the participants are required to have evidence-based practices, those that are appropriate for children and families, the parent management training Oregon model, and parenting through change, and trauma-focused CPT are sort of examples of some of the services that those providers are required to have as part of the service delivery. The issue is that we exclude in the public mental health system individuals whose problems aren't severe enough, if they're not in crisis, and if they don't have Medicaid. I think additionally, as it's already been noted, the pandemic has just exacerbated staffing issues throughout organizations around Michigan. In order to address, I think, these issues, a solution that addresses root causes is necessary. And I believe that the new federal model related to certified community behavioral health clinics is a solution that should be adopted. And I'm pleased to say I was really happy to see the department come forward with an expansion proposal. I wanted to share with you a little bit more detail about the organizations that have been working on CCBHC and are essentially shovel-ready, if you will, to participate. CCBHC is important because it both has standards that providers need to meet, as well as it has a financial model that takes the cost of care into consideration. And I'll share a little bit later, it's also a great deal for Michigan in terms of Currently through 2027, the state's participation, the cost of participation is only 20% of every federal dollar, compared to the current state match of 35%. So it's, I think from both programmatically and financially, it is a very good deal for Michigan and would advance transformation of the public mental health system and opens the door to people without regard for their source of payment. So then in communities right now, people are sorted based on whether they have Medicaid or not. That would not be the case for CCBHCs. The door's open. Currently, there's 13 organizations, and the demonstration is not that large. I've listed the organizations in a handout that we've provided you. Shows you the name of the organization and the PIHP they're affiliated with. These organizations are all organizations that were early adopters of CCBHC. My organization, the Guidance Center, is part of the demonstration. We were active planning to become certified when the legislation was first passed. We were excited. And I just have to say, personally, for me, I've been involved in community mental health since the early 1980s. And one of the sort of lifelong frustrations has been when you encounter families who have difficult situations, but they have means, but they can't find what they need to get help. The public mental health system has that array of services that can help. The door needs to be opened more widely, and this model does that. So I think that's an important transformation of our system. Michigan, as you know, had a planning grant, was not accepted initially. It took 4 more years, I believe, in order for Michigan to finally be qualified to be part of the national demonstration. So 2 years ago, the door was open to Michigan and Kentucky, so there's 10 states now. But there is a plan to expand this program nationally by 10 states over the next several years, every year. The SAMHSA grants, as Sean had mentioned, were a solution that Senator Stabenow advocated for because Michigan was not part of the demonstration initially. She wanted to see organizations in Michigan have the capacity, build the capacity to qualify as CCBHCs. And so in Wayne County, I'm listing the 9 organizations that are part of that. They're private nonprofit organizations like the Guidance Center. Most of them, as Sean has said, have capacities to integrate healthcare and mental health care. They address issues around social determinants of health, housing, and other issues. The other 15 organizations, so there's 37 total organizations in Michigan right now. Only 13 are in the demonstration. There's 24 more that could potentially be qualified, and I've just listed them there in case they're organizations that you might know of in your area. I believe CCBHC makes sense programmatically and financially for Michigan to address unmet mental health needs for children, families, and adults. It opens the door widely to people without regard for the source of payment, and also does not require that they be in crisis. So that's a really important shift, I think, that we need to emphasize access to routine mental health care and not just crisis services. We need to provide services early on when people are motivated. The current announcement, as I mentioned, is a very positive development. I think the one shift that we would like to see, and I support what Sean said, if you look at the organizations in the Detroit-Wayne area, there's 9 private nonprofits that are currently not eligible to apply for the expansion. And we would like to see the department open the door to those organizations that have SAMHSA grants that are not designated as community mental health service providers. Currently, the department's expansion is limited to only those organizations that are community mental health service providers. And, you know, we think that the expansion's great. In Detroit, the service delivery historically has been provided by private nonprofits. And so we're the most populous region in the state. Currently, only the Guidance Center is participating. We'd like to see our peer organizations that have been planning and working on CCBHC be given the opportunity to apply. So thank you.
I'm Dr. Bob Hull. Can you hear me? Off to a good start. And I get to go last, so they've said everything. Yeah, so I'm Dr. Bob Powell. I'm from Jackson County. Woo. We're unique. We are urban, small urban, and primarily rural. So that brings a whole nother set of issues to care and accessibility. I'm faculty at Western Michigan University, and I am the CEO of Family Service and Children's Aid. We're right downtown in Jackson. We specialize in traumatized kids and families, and I'm going to keep talking. I'm going to drive the trauma piece home here. We offer substance use disorder treatment, mental health, foster care adoption, parent education, juvenile diversion, and a lot of programs that I'm not even going to list. So we have a unique perspective with regards to working with extremely poor families. The city of Jackson has really concerning demographics when it comes to poverty. 88% of our clients and families, kids and families, are below the poverty lines. And so we have to really raise funds. And poverty, as you know, is a social determinant of health. And with that comes a lot of correlations. I wanted to talk about the same things, right? Especially post-pandemic and what is really difficult for we're considered a mid-size nonprofit. Some are large, some are small, we're mid-size. And the nonprofit world is brutal right now. Staffing, absolutely. And what goes along with that is our rates. So our unit rate is about $125 per session. So what goes into that? Administrative costs, reception, billing, supervision, and then paying our therapists. And Deborah said about $50,000. I wish. We're paying our master's level clinicians about 46. Now think about it. They went through grad school, right? And they can make more money supervising over at a coffee shop nearby, Starbucks. So why would they take on student loans and go through all the trauma of working with traumatized kids and families? And so, you know, we need help incentivizing this. Certainly, we really like the trends with incentivizing students to go to grad school to get a master's in counseling or social work, but that's not enough. Retention, as Sean indicated, the what I call unfunded mandates, right? All the paperwork. So we're a provider for our CMH, and we have state contracts and PHIP. And our PHIP, we have to offer up to 50 reports, right? Unfunded mandates. Our rate has to cover all of that one session rate, all right? And so I'll give you some specifics there. Our Medicaid, which is our primary kid and family, $63. Remember, my unit rate's $125, right? The Blue Care Network and Aetna, $72. Blue Cross, the Cadillac, $89, right? And so every month when I go through my financials, we have a process that we call discounts. that I have to take right out of the insurances that we built because it doesn't cover it, right? And so how do I pay my people, my therapists, and for that matter, my foster care workers, right? Same thing, the rates. And the additional thing under unfunded mandates is I have to have supervisors that are regulated with 4 years experience, 6 years experience, master's level. And, you know, how do we pay them and compete with our local hospital or our CMH? Or they go into private practice. Yeah, the rates are a big concern. And then I did want to personalize for you what our kids look like, right? So let's talk about trauma. Hopefully you've heard of adverse childhood experiences. If you have not, I'm really going to advocate that all of you go through the training. I happen to be a master trainer, and we do a virtual every month. It's a 3-hour, but it will absolutely change your perspective on children and adults and why they struggle with what they struggle with. So our kids, obviously, we work with our foster care children, and we're known for traumatized kids and families, and they come in with severe abuse, neglect, misdiagnosed ADHD because it mirrors trauma, and certainly poverty. But what I really want to hit home here is recovery, addiction, right? And these kids their parents are struggling with addictions. And before I forget, that rally over there is the UFAM. So please go over and support them. My team is up here, and that is statewide, celebrating the recovery services that we offer in the state of Michigan. At any given time, 80 to 100% of my kids in foster care are in foster care because of addictions. 100%, right? And so co-occurring mental health and drug treatment is so important. We do offer women's specialty. We're one of a few in the state of Michigan. What that means is I have to raise funds to subsidize it, but they specialize in women in recovery that need daycare and transportation and some basic needs met just so that they can attend their groups or go through their recovery journey. So that's what the kids look like. And then we really haven't hit on adolescents, have we? I wanted to give you a story, an anecdotal. I can give you data all day. My colleagues have done that. I wanted to talk about Trevor. I chose Trevor because often the authorizations for care are a real challenge, right? So we have a state contract, and so we have to start off with 12 units. Okay, these kids have gone through abuse and neglect for years, and we have to start off with 12 units, and then we have to re-auth every time, and they may or may not give it to you. And even some of the insurances like Medicaid, it's 26. So that means every other week for a year if you're lucky. And these kids need weekly. And so Trevor, he came to us when he was 12. Mom was working poor, not a lot of supervision, and he was raped by one of her boyfriends. And mom struggled with addictions. We did not know that. He was acting out, and we worked with him, and we built relationships, and we worked with him, and we built relationships. He did not disclose the rape for a year and a half, right? And so he became what I call one of my free kids, because we didn't have authorization anymore to work with this kid. But we're not going to turn anybody away that needs help. So then we have to subsidize that. We have to raise money and United Way and grants and beg, borrow, and do whatever we have to do to try to balance our budgets. Trevor went on to be suicidal. And there is a huge gap in child and adolescent psychiatric care, right? The closest hospital for our adolescents is Havenwick. How do my families go see that kid when it's an 1.5 to 2 hour drive for them? How do they support their kid, right? And so we really need to look at psychiatric care. Another prime example is in child welfare. If a child is a threat to self or others, we take them to the ER, and that we have to wait for a bed. And my child welfare workers, my foster care workers, have sat there for 2 to 3 weeks because they won't admit him because there's not a psychiatric bed in the state of Michigan that will take him. So he sits in a room, and my staff have to 24/7, because he's not admitted, have to sit in the ER. So I cannot stress the importance of psychiatric beds in the state of Michigan for child and adolescent. And so I would offer a few solutions as well. Higher rates for behavioral health, and I'm going to throw in foster care as well. Longer duration for treatment. That's why I told you the story of Trevor, right? 12 units, and he suffered with addiction, addictive parents and rape and just horrible things. And we worked with him for over 2 years, and he still ended up having to be hospitalized. And then staff supports, certainly. School loan forgiveness, incentives. What my colleagues did not mention is in 2022, there was a 50% vacancy rate for master's level clinicians, and that includes the graduating class. And so our pay, not only to sign-on bonuses, but retention is the key, I think, to success. And then I would be remiss if I don't advocate that you all go through an ACEs training and that we have trauma-informed legislation. And then one other thing, we do school-based mental health. We go to the site because our transportation in Jackson, public transportation, ends at 6 o'clock. So if the parents work, how do you get the kid to therapy and back? And we're not even talking rural, right? You got to do in-home there. And so there's a lot of buzz and funding coming through for on-site mental health in the schools, and I cannot advocate for that enough because then we can see the kid in the school. Thank you very much for your time.
Thank you all so much for the testimony. It's really important for us to be able to understand. Dr. Hall, I really appreciate you bringing in Trevor and speaking to him and some of the really very real, very complex and complicated structural issues that we need to attend to. I do know that a couple of things, Rep. Glanville, Rep. Price, myself have all worked on some telehealth because we know the importance of that, and knowing that things are ending with the emergency order ending, and how we are reaching more people and being able to have success with that through that. Not only in spite of 42% of folks in the southeast, southwest Detroit area having connectivity issues, but just folks who wouldn't normally come in. We're reaching those folks too. So I really appreciate that. Administrative burden is also another issue that we've been looking at and have a bill around. So those suggestions are really helpful, and ones that have, I feel like, historically been problematic, and we need to figure out. Colleagues, what questions do you have? Rep. Reingans.
Thanks, Chair. Thank you all for being here and talking about such difficult and very complicated things, touching many agencies within MDHHS like child welfare and also Medicaid payment through the PIHPs. So those are like two different areas within the department and different financing that comes to you as one organization. So it's very complicated for you as an organization, but also for us to understand if we don't work there. One question I had was, so I have two questions. One's about administrative burden, and the other is about audio-only telehealth. Mr. DeFore had mentioned audio-only telehealth as something to think about, and this is a policy that is determined by our state's Medicaid office, so they can determine what they will reimburse for. This isn't something that must be legislated, right? So this is solidly in the administrative branch of government in Michigan. It's not something within our legislative branch. It could be. It doesn't have to be. And if it is, it's a little bit strong when the administrative looks at it, because it is something that they can choose to do or not do, but they would have to do it if we told them they had to. So I just want to make sure everybody understands that this is something that the state can choose to do or not do within the department. As far as audio only, I know that when I was in the department in the behavioral health area, we were debating a lot about audio only services during Medicaid. I worked there during COVID. And for behavioral health, some behavioral health services, it was very, very beneficial to patients, as you were describing. And so for some physical health services, it's much less beneficial. So how would you craft the Medicaid policy recommendation as far as, like, you're in your ideal world, if Medicaid agreed to allow audio only, is it for certain types of behavioral health services? Would there ever be any sort of like in-person periodicity of needing to come in? And how often would that be? And this is open to anybody. I just directed it to you because you asked the question.
Yeah, and I'm happy to address it. Thank you for the question, Representative Reingens, and for the detail about the administrative decision-making versus legislation. And I think the challenge is despite our best advocacy at the state level, and we were pleased with some of the flexibilities that are in the current policy, it still didn't go far enough. So even if it's not legislated, having legislators put pressure on the department to relook at this can be helpful. And we can certainly give feedback to the department on how they should craft it. Personally, what I would like to see is a more person-centered approach to deciding what medium is most effective for a family. And to me, if between the consumer and the clinician, that decision could be made based on what is most convenient for them. And as long as it's documented in the person-centered plan, when it's audited by DWIN or Medicaid, it can be challenged if there's a concern about the provider pushing it as opposed to the consumer really needing it. And I would say for multi-problem families in poverty, audio only as an option should be something that's made available to them. Individuals who are inconsistently housed or sort of living on the edge of homelessness, audio only should be made available to them. Seniors and near seniors over a certain age that we know consistently have trouble with some of the more current technology, to me, it should be made available to them. But ultimately, I'd prefer to see it as a decision between the clinician and the consumer about what medium is best for them. And we can certainly document why and justify it in the plan.
Thank you. And I remember when we were debating it internally, I was really proud after I had left the department and saw the policy be posted that it was the determination about audio only continuation was based on whether it was what the patient wanted, not the clinician. And my husband is a clinical social worker, and he rolled his eyes at me when I told him that because I was making things more difficult for him. But he's doing that job because he wants to serve people, so he got over it real quick. Plus, he didn't want to fight with me. So the other question I had was about administrative burden. I know Rep. Brayback talked about having a bill for this. Many of the things that an on-the-ground clinician in a public behavioral health contracted entity here in Michigan has to do are things that comply with various audits. The various funding streams that come into the state that then go out to the providers have quality programs where you have to do certain screenings and assessments and things. And so there is a lot of overlap in some of these. There are also different data systems between private, nonprofit entities in a community and then what gets filtered up to the state. So I'm curious if you have like specific suggestions or ways that we could add to legislation if necessary, but is this something that needs to be legislated?
So, sorry, I don't want to dominate here. And I missed answering a piece of your last question too, Representative, which was, are there places where audio only might not be appropriate? And I agree that there are, particularly around psychiatric assessments or certain prescription of medications and monitoring. But again, I think with the psychiatrist and the consumer, let them decide what is most appropriate and make the limitations very limited for when audio only can't be used. To your second question, and thank you for that as well, we recognize that there are lots of federal level requirements that the state has to comply with. Part of what we've heard from our PIHPs is that there are lots of state level requirements that they have to comply with. And when you add all those up, by the time it gets to the provider and clinician level, you have lots of redundancies and lots of paperwork. What we haven't yet seen is a state level effort, a collaborative effort to say, let's take a look at all of these requirements and figure out where we can eliminate redundancy, and where we can create some consistency across the state, even within the PIHP structure. And we've advocated with our PIHP, and the challenge is their response is generally, well, we have state requirements we're trying to meet. And I think what we're just asking is, maybe it's not legislated, or maybe it's just legislated that a administrative burden work group be formed by the state and report back to the legislature, and let the providers, along with the PIHPs and the state, find where there are abilities to scale back, because we know that there are. And we've done some analysis. Happy to share that with you outside the hearing if you'd like as well. But there's some possibility there.
Great. Thank you so much.
I would add, we have, like, one therapist would have to work through like 4 different platforms. So it's not just the paperwork. They have to learn the CMH system, the PHIP system, the state system, and be able to navigate all of that. And each one is not necessarily customer friendly. So I would look at a standard platform that everyone can buy into. Good luck with that.
Thanks. That's why we do the hard work over here.
The other thing about administrative burden that I would add that, and I can't remember, I apologize, one of you mentioned this, but we have clinicians who are trained to do mental health care work with their clients who are spending, I think it was 40% at least, of doing paperwork. That seems egregious to me, that we're not using their talents and their expertise in the way that it was meant to, and instead we're having them redo reports that they've already done. And so, yeah, I mean, this is just something that I think we really need to seriously look at and make some changes on. Rep. Thompson.
Thank you very much. You guys did a fabulous job of giving us the information I think that we've been needing to see. Coming in initially a few weeks ago, educating us a little bit. Then we had some families come in that actually said a lot of the opposite things that we were told the first time. And then today you guys kind of came in and said, here's the why. So that really opened our eyes for me personally. So the sad part that we hear as legislators from our constituents is there's many families that feel that CMHs, I know we're now, the big push is this CC, BCH, but they feel that they're being failed. They feel that their children are being sent home from facilities without a safe plan in place or a strategy or prescriptions or follow-up appointments. Some of them have even come to us and said that they have been threatened with CPS because they had another child at home, and one child had an SED diagnosis or was dangerous to themselves or to their parents. And they said, please don't send them home. Can we just get a plan in place? When is their next appointment? Are they going to meet with the doctor for their prescriptions? And they said, well, if you don't come pick them up, we're going to call CPS. So families are coming to us with so many concerns that are heartbreaking, and I see the frustration in your faces. So I'm glad to see that it feels like maybe for the first time, which I know I've only been here for 4 months, but for the first time it feels like everyone's coming to the table to work together. And something that Mr. Walker, so the Downriver Guidance Center is very close to my district, being in Downriver. It's the only facility we have for mental health services. You said something that really, and I wrote down and circled it, getting the interventions in place early on when motivated. And that makes a lot of sense to me because that's what I've seen in the frustration with families is they have something going on with their child. They reach out to the guidance center. They make an appointment. Right now, because of your lack of staff, if someone were to call and say, I have something going on with my child, I think they may be getting bullied at school, they're going through some depression, they're anxious, things are changing, their grades are slipping, I really think maybe they need counseling. And this particular person does have Medicaid, so they would qualify, which I'm sure, and another part we need to figure out is the people that aren't qualifying and how can we get them those services. what does the time frame look like just for the intake appointment? To sit down and see what's going on to get that intake, and then the next step would be to see a psychologist and begin counseling, and then possibly the time frame from the psychologist to a psychiatric appointment if they request medication. If you could answer that, and thank you guys so much. We're here to listen and to work with you guys on this. I think everyone on this panel is ready to say, let's start figuring out what's going on here. So if you could answer those questions, thank you.
Sure. The Guidance Center, has been around since 1958. We're kind of the go-to in our community. I think we've got recognition by the schools and the communities. We are able to see people within 10 days of their call. Right now, because of our participation in the CCBHC, people without Medicaid, people without insurance, or people with private insurance are able to gain access in that time frame. We also start treatment within 14 days of their intake. And so these are kind of a couple of standards that are part of the CCBHC model. One of the, I think, important aspects, and that I think is first that I've seen in Michigan from a provider perspective, is that the CCBHC model also has a value-based component, which is that if the providers meet these performance standards and meet these benchmarks, there's a quality bonus payment potential for the provider above and beyond the reimbursement. That is really kind of a first. There's been a lot of talk in the industry about value-based contracting and, wanting to reward performance and those sorts of things. I have never seen it apart from the demonstration that we're in. I think that's why I think it's a model that is exciting and should be embraced and expanded. And I think the transformation statewide is going to be dependent upon how big of an expansion we can afford to do.
Can I just ask what type of organizations and agencies you said, because you said there needs to be more agencies that are allotted?
And, currently the expansion is going to be limited to those legacy county-based community mental health centers that are they're designated in state law as CMHSPs, community mental health service providers. In Detroit, DWIN is both a CMHSP and a PIHP. And so they would be eligible to apply. The Guidance Center will continue to be a part of the demonstration as well. And the other, CNS Healthcare will be a provider as well, and Easter Seals will be a provider as well. But we would like to see, there are 9 organizations in Wayne County that are private nonprofits that have been working on becoming CCBHCs. Some of them, like Sean's organization, the Southwest Solutions, and also development centers that they're in the middle of a merger, are both CCBHC SAMHSA grantees. Their grants run out this year. They run out by September, and if they don't have a pathway, there's a loss there. And so I'm not opposed to CMHSPs. I just think the proposal should be an and allow these organizations that have SAMHSA grants to apply. Mm-hmm. If they don't qualify, fine, but at least they weren't even being allowed to apply to be part of the demonstration. And in the Detroit-Wayne area, the bulk of services are provided by these private nonprofits like the Guidance Center, mm-hmm. Southwest Solutions, the Children's Center. We have a long history of working together as organizations. In fact, Southwest Solutions and the Guidance Center have a joint venture together with serving delinquent youth in Southwest Detroit and Southern Wayne County through an organization called Bridgeway. It's not part of the mental health system, but we've worked on a lot of creative solutions to issues in our community. I think the CCBHC is a very promising one, but let's not block the private nonprofit sector from being part of it.
Thank you.
And if I could add about that is that the two primarily children nonprofits in Wayne County, which is the Children's Center and Starfish, we've been denied getting even the first phase of the CCBHC, primarily because we're mainly children focused. So of course, the CCBHC is wonderful and all of the components that are necessary to get that work done. And we're concerned, we're applying again tomorrow, I think it is, for the initial grant. And we're concerned that if we don't put more focus on organizations that provide for children, that leaves us out for no good reason, because we have partners in these others to do the adult part of the work, the substance use part of the work. So we're hoping to be successful in getting on the first track of being able to do that work, because we see a high percentage of our businesses with children.
I have
So
heard of Starfish.
hopefully we-
heard of
pardon
that.
me?
I have heard of Starfish.
Yes, Starfish and Children's Center, we're the ones in Wayne County who have been consistently denied access.
Okay.
At the first step, so.
If I could also answer Representative Thompson, we have a 3 to 6 month wait list depending on the issues, and so does our CMH. So all the providers in Jackson County, Kathy, they bounce around and they will call you, and we're all in the same boat because we don't have capacity.
It's more likely for people to give up
Absolutely.
and then just say, you know what, it's too hard to get access. Just we'll worry about it later, or if it happens again, we'll worry about it. And then the longer that they go without getting help, the
More
harder it is
complex,
to. Yep.
yeah.
Minority Vice Chair Schmaltz.
Thank you, Madam Chair. I appreciate the testimony from all of you and all the care you have. You can tell that you have a real heart for helping. I'm familiar with the Children's Center, and I do believe that these grants should be available to all of you. Dr. Powell, it's great to see you. Thank you for all the work you do in Jackson County and all the families and children that you have helped. I had the pleasure to work with you with the Wendy's Charity Classic for adoption, and hopefully we don't do that anymore, but I hope to bring something back to help you out with that. We're working on that. I do believe it's so important to work on access. We want to make sure everybody can get the help they need, the telehealth, the audio. I would like to see that expanded and covered. Also, transportation for parents and families to get to where they need to go. I think that's an issue we really need to work on. Mobile units is another thing. I hope we can work on that. We talked about, trying to get people to work in this area is very hard, especially these days. And we have, of course, so many more people. I met with the college presidents in Jackson County, and they have never seen such an increase in behavioral health problems on their campuses. So it's a broad spectrum of problems with all of our children and our young adults. Student loan forgiveness, the administrative, the paperwork. What else can we do to help in this area to find employees?
Sorry, I think those are great starts, and to the legislature's credit and the governor's credit, there certainly has been some expansion of student loan forgiveness and support for behavioral health workers, which I think has made a big difference. To me, the administrative burden relaxation is an immediate solution, because it's going to take probably 5 to 10 years to get people back into those master's programs and coming out and then licensed and ready to practice. So we need some solutions immediately that will increase our capacity with what we have. And I certainly think that's one option. It could also help us bring people back, if there are additional incentives in working in public mental health, back from private practice and hospital systems. I think the other is the governor and the legislature have done some work on teacher recruitment and retention efforts. And if recruitment and retention for behavioral health workers could mirror what we're doing for teachers in this state, I think we could see a lot greater retention and recruitment. And that's things like mentoring programs, sign-on bonuses that are supported through state-appropriated funds. Those are just some small things, but I think that roadmap for teachers is something we could follow for behavioral health workers, if that's helpful.
I think another continuation of some of the pandemic related allowances that were made related to credentialing. New grads that maybe did an internship but didn't work the full year with children and families, but are willing to work in the public mental health system and can work under supervision should be allowed and be reimbursable. And I think, there are some things like that. I think easing the requirements in terms of who's a reimbursable employee in community mental health would be helpful.
Thank you for that. I also was just thinking, I know we do this in Jackson County a lot, different groups like Family Services and Children's Aid, talking and collaborating with other groups, Big Brothers Big Sisters, Easter Seals, working together. I think that's really beneficial for children, especially going through mental health areas, and for adolescents, because they see other kids going through same things and they realize they're not alone. And I think if we have more collaboration between different agencies in our counties and other counties, that could probably help in this area too. Just a thought.
And we do a lot of that collaboration. To give you an example of low rates, we had a youth peer support program that we recently ended because the rates were so low, we could not pay those youth. So you're right, they were impacting their peers because they'd lived that experience. And so it really hurt me to have to drop that. But I think it was like $8 an encounter, for doing that work, and it's ridiculous. Even though they're a young person, they deserve to make a reasonable wage. We couldn't pay them what they could make at McDonald's, and that's just not good. So those types of services are very critical. We were able to keep our adult peer support program, but the youth program just rates way too low. So that's going to be the key, I think, is looking at those rates, whether it's Milliman or somebody else, although I don't have the greatest respect for what they've come up with in the past, but someone who can really look at the true cost of doing this work. A public system should have access without fail. And the only way we can is if we can cover our cost in this competitive environment. One last thing I'll add, I have a daughter who's a master's level social worker who makes $80,000 a year, sitting at home, doesn't have to leave her bedroom at all to provide services through, I think it's BetterHelp or something like that. And so there's a place for things like that because it's primarily private pay. They pay X amount a month and they get, limits, but pretty much whatever kind of mental health care that they need. So they've got great access, and it's audio and video. And so, something that allows us to be able to mirror that in a way. We would never be able to pay $80,000 to a social worker that's just been working 3-4 years. But we've got to have some alternative to maintain people like that who, really want to do the work. She will sit there for 10 hours and talk to people on the phone and do video and had really great success, and her audience is worldwide. So if we could think of a way to offer that level, and I think allowing the audio and video for telehealth will go a long way with that.
Thank you.
Mr. DeFiore, one of the things that you said reminded me of some of the work that Rep. Edwards and I are doing around licensure for MSWs, and one of the things that we saw in Illinois when the requirements shifted so that, if you don't pass your licensure exam within 6 years, then you can never try again. When they impacted that, the influx of social workers that came. So there are those short-term and long-term solutions, I think, that we need to be looking at. But that's one of the things that Rep. Edwards and I are working on as well. I want to welcome Director Hertel. Thanks for being here with us this morning. We have one more question. Rep. Glanville.
I'll be brief. Thank you, Madam Chair. And maybe this is a conversation we can have at a later time as well. But I just wanted to get a little clarification on where we are in the budget with this expansion. And so I know, I talked to you about it a little bit. There's $9 million included. Does that cover all of the groups that are on this list we have here, or do we need? Because I see, this would support organizations on the west side of state, and I don't know, in particular in the Grand Rapids area, and I'm not sure that we would have CCBHC access otherwise. So just wondering, do we need to advocate for more, or are we good?
My opinion, sorry, Director, is more.
Of course, but
I mean, when we talked about the 9 million, that was before the announcement from DHHS came out. And I know I was very excited to see that. And so, I'm hoping that we see that number increase during budget negotiations, because we do know that there are entities throughout the state that have been working towards this and want to be able to be part of the CCBHC system that we're setting up throughout our state. So I do think it's something that we should continue to talk about and advocate for.
okay, glad to see. I mean, happy to hear all of this when we talk about we opened today with the expansion, and our colleagues were talking too about how this access to care, Medicaid or otherwise, and the CCBHC seem like they're doing that job. So, thank you.
Thank you all. We don't have any missing members today, so thank you all for your work. We'll continue on all these issues and subjects, and please, if there are ideas that you have and things you want to hear about, I've already gotten some feedback. We'll try to bring folks in, but I appreciate all of your partnership on this and this very complicated, complex issues. And with that, we are adjourned. Thanks, everybody.